Hey everyone, welcome back to Izzy Medicine, where we try to break down the big, scary medical topics into something you can actually understand. And maybe we can even enjoy some learning in the process. Today we're diving into one of the more dramatic characters in the endocrine system, Pheochromocytoma. This one is fun, not for the patient, obviously, but fun to learn because of the cool presentation, the interesting physiology, and the what, why, and how of it all. So let's get into this. All right. Imagine you're in the ER clinic and your patient says they've been having these random episodes where their heart feels like it's racing, it's going to explode out of their chest. Their head starts pounding and they suddenly get drenched in sweat. And then just like that, like an off switch, it's over. And they say it feels like a panic attack, but their blood pressure was 200 over 110 last time when they measured, and they swear that they weren't stressed. And these episodes just come out of nowhere, they say, and there's no clear trigger. They weren't exercising, they're not stressed, they don't smoke, they didn't drink caffeine, and they don't usually suffer from anxiety, but that's what it felt like. So that right there is your first clue. Pheochromocytoma loves to masquerade as anxiety or panic disorder. But the triad of headache, palpitations, and diaphoresis with paroxysmal hypertension, that should set off alarms in our head. Now let's talk about what's causing all of this chaos. So inside of the adrenal gland, in the center, is the medulla. This part of the adrenal gland is packed with chromaffin cells, and they're your fight or flight hormone factory. Normally, they make norepinephrine and epinephrine when you're under stress, and like if somebody just jumps out and yells boo, and that can spike your fight or flight response. Or when you suddenly realize that you forgot to do 5 out of your notes and they're due tomorrow because the office manager needs to send them to billing. That also can spike your norepinephrine response. But in pheochromocytoma, one of those chromaffin cells turns into a tumor. It stops listening to normal signals and it starts firing off catecholamines, norepinephrine, epinephrine, whenever it feels like it. There's no threat, there's no reason, it's just chaotic. And instead of a short-lived appropriate response, now you have these bursts of these hormones flooding the system and activating adrenergic receptors all over the body. That's why the symptoms come and go. This tumor doesn't constantly secrete, it just does so in episodes, and during these episodes, the patient's cardiovascular system goes into overdrive. So let's zoom in and figure out how this plays out in the body. What happens to cause the symptoms? So to start, when norepinephrine binds to alpha-1 receptors, it causes vasoconstriction, and that raises systemic vascular resistance, which leads to sudden severe spikes in blood pressure. That's the headache. Not just from the pressure itself, but from the abrupt changes in cerebral perfusion that the brain tries to auto-regulate. Just vasoconstriction, no vasoconstriction, vasoconstriction, no vasoconstriction. The body is just not knowing what to do with all that elevated blood pressure and this dilly-dally that is happening inside of it. And because the body fails to auto-regulate, there's a headache. Meanwhile, in addition, norepinephrine and epinephrine hit beta-1 receptors. And beta-1 receptors, when they're hit, you get an increase in heart rate and contractility. And the patient might describe palpitations, pounding in their chest, and feeling that their heart is trying to punch their way out of their rib cage. And that's a very, very uncomfortable feeling for the patient. And sudden, too. And lastly, we have diaphoresis, excessive sweating. Well, this one's a little bit less straightforward. There's kind of not a clear consensus, but it's thought to be from activation of the hypothalamus, the body's internal thermostat. When catecholamines stimulate the hypothalamus, it can reset temperature regulation and trigger sweating. Another theory is that there's direct stimulation of sweat glands through the cholinergic pathways. And basically what the body's trying to do is release heat and calm down in response to all of this catecholamine overload. Now, here's where we take a detour into something every student needs to know for the exams. I needed to know it many years ago. It's the rule of tens. It's an old mnemonic, but it still holds up. About 10% of pheochromocytomas are bilateral, malignant, extra-adrenal, Those are called paragangliomas, seen in children and are familial or genetic. So 90% are unilateral, benign, occur in adults, and are inside the adrenal gland, and are sporadic and not related to familial or genetic issues. So that's the basic pattern. But don't forget, genetic causes are more common than we used to think, especially with the advent of testing. So if the patient is young and has bilateral tumors or has a family history of pheochromocytoma, you need to think about syndromes. So let's talk about these fun syndromes. So MEN2A, MEN2B, von Hippel-Lindau, and NF1. These are the big syndromes where pheochromocytomas tend to show up as part of the larger endocrine picture. So let's review. In MEN2A, pheochromocytoma is usually paired with medullary thyroid cancer and parathyroid hyperplasia or parathyroid adenoma. In MEN2B, we'll also see medullary thyroid carcinoma. We'll see mucosal neuromas, which usually are on the lips or the tongue, and a Marfanoid body habitus. So we'll learn about Marfan syndrome at some other point, but long limbs, joint laxity, and a body type of a tall person that's usually skinny. It might remind you of Marfan syndrome. In von Hippel-Lindau disease, pheochromocytomas can appear along with retinal and CNS hemangioblastomas, renal cell carcinoma, and pancreatic cysts or tumors. And lastly, in neurofibromatosis type 1, NF1, the classic trio is cafe-au-lait spots, neurofibromas, and occasionally pheochromocytomas. So this is why we don't want to miss the skin exam, because we will find this cafe-au-lait spots and neurofibromas if we suspect pheochromocytoma. So if you catch a pheochromocytoma in a young patient or it's bilateral, just feels off, look for the rest of the endocrine family reunion. All right, so now you're suspicious. Your patient came in, they have a headache, they have palpitations, they're sweating profusely, they have blood pressure that is elevated on occasion. What do you order? How do you find this? How do you confirm this? So what you do is you start with biochemical testing, and specifically you're going to look for catecholamine breakdown products. The reason we're looking for the breakdown products is because the actual hormones fluctuate too much to reliably catch them in action. So we test plasma-free metanephrines, or we do 24-hour urine collection for metanephrines. So these are more stable than the parent hormone, and they give us a much better chance of detecting this excess catecholamine production, even if the tumor only secretes intermittently. What you would need to order for the patient is you need to order a urine test, and the lab gives them a jug, and they pee in the jug for 24 hours, and then these levels get tested. I recently had an interesting situation where I gave a lady a test for this, and the lab forgot to give her the little plastic toilet commode to pee in, and my patient was trying to pee directly into the collection device and called me because she was missing the container. And I said, they didn't give this to you? And apparently the lab didn't think to give her the little plastic urine collector, and we had to redo the whole thing, and I had to tell the lab to please give this. So sometimes interesting things happen when you collect urine. Patients also ask you if they need to refrigerate it, and they're kind of icked out about putting a humongous jug of urine in their fridge. Just an aside, I digress. Another side note, the patient needs to be lying down and resting for at least 30 minutes before you draw plasma metanephrines. No caffeine, no stress, no sneaky exercise beforehand. You want to test to be accurate. So that's why we need to keep their nervous system not excited. Next up is imaging after the labs, because if the labs are high, you need to find the tumor. So what you do is you get a CT or MRI of the abdomen, looking at the adrenal glands. If that's normal, but you still suspect something, especially if you're thinking extra-adrenal disease, you can move on to an MIBG scan. That's a nuclear medicine scan that specifically looks for catecholamine-producing tissue. So, ta-da, you did all of this and you found it. What now? What do we do? Surgery is the definitive treatment, removing the tumor. But here's where a lot of people get tripped up. You can't just rush them into the OR. If you poke or manipulate that tumor without preparing the patient, you risk triggering a massive catecholamine dump right there on the table, and you're going to have a person that's very, very hypertensive, and that's very, very dangerous intraoperatively. So that's how you take somebody from mildly hypertensive to full-blown hypertensive crisis. So you don't do that. You can't manipulate the tumor and have it release all this disaster. So we prep them carefully. The very first thing that we do is alpha blockade. Typically we use phenoxybenzamine, which is an irreversible alpha-adrenergic blocker. It relaxes the blood vessels, it lowers systemic vascular resistance, and reduces the risk of dangerous blood pressure spike during surgery. And the timing is very important. Alpha blockade isn't just something you do the night before. We have to start it at least 10 to 14 days before surgery, and that gives the vasculature time to dilate and allow the patient to expand their plasma volume again, because chronic vasoconstriction from all that norepinephrine tends to deplete it. During those days, we usually recommend a high sodium diet, which is counterintuitive to what we usually recommend, and we increase fluids as well in order to replenish volume during this vascular dilation. And what that does is it helps expand the volume, and it helps prepare them for the shift that happens once the tumor is out. Once the alpha blockade has done its job and the blood pressure is controlled, then and only then we add a beta blocker, usually something like propranolol. I want you to understand why this order and why not the other way around, because just remembering alpha then beta is okay, but I think understanding is better than remembering. So what happens is in pheochromocytoma, there's already way too much catecholamine floating around, as we know, and that means that all the receptors, alpha and beta, are being stimulated. Now, if you were to give a beta blocker first, here's what would happen. Beta 1 receptors on the heart normally respond to catecholamines by increasing heart rate and contractility. Beta 2 receptors found in blood vessels, they mediate vasodilation. If you block those first, you take away the heart's ability to compensate and remove one of the only things fighting against vasoconstriction, which is the vasodilation from beta 2 receptors, and you also decrease their heart rate and change the output. But the alpha receptors are still open for business, so now the catecholamines have nowhere to go except alpha 1 receptors, so because the beta ones are blocked. And so all the catecholamines are going straight to the alpha 1 receptors, stimulating them again and again and again and again, and this tightens the blood vessels. With the beta 2 receptor dilation removed, which was a little compensatory, now we have unopposed alpha stimulation, and that causes severe vasoconstriction, and that causes a severe spike in blood pressure. So, and even worse, like I mentioned, the heart, now beta blocked, because now it's slow, can't compensate. We've taken the ability to increase output in response to stress because the contractility slowed down. And that combination of high afterload and basically a hamstrung heart is a recipe for disaster. So we don't do that. So that's why alpha blockade first always comes first. You open up the vessels, you reduce resistance, you stabilize blood pressure, you make sure that they're not volume depleted, that there's sodium, that they're replenished. And then after all of that is stabilized and their body's used to the blood pressure as it is, then you add the beta blocker to slow down the heart and protect against arrhythmias during tumor manipulation. So it's not just a protocol or something to remember. This is a patient safety maneuver that's very, very important. Once they're prepped and stable, you take out the tumor, and most of the time that's curative. But post-op, you still want to watch them carefully. The blood pressure can drop fast, and sometimes patients have persistent hypertension or residual symptoms despite the removal. So that's it, guys. This was pheochromocytoma. I hope you enjoyed. I hope next time you see a patient with palpitations and a headache and some sweating, you don't immediately jump to think that it's anxiety and maybe think, it might be a pheochromocytoma, and investigate. Thank you so much for sticking through this, and I hope you learned and I hope you had fun. If you did, please don't forget to subscribe and like and comment if you have any questions. And until next time, keep learning, stay curious, and I'll see you later. Bye.